Good evening, everyone, and welcome to tonight's webinar. Thank you for choosing to join our webinar tonight. I know it's a few minutes later than usual, but it's just because of the time difference between London and South Africa. Some housekeeping rules for the webinar tonight. Dr. Sulieman will present his presentation, and afterwards we'll have a question and answer session. So feel free to load your questions in the column section or the chat section, and we'll get right to them. At the end of the webinar, I'll have a little or cover a few promotions. I'll be about 5 minutes, so please don't run away. We've got some exciting stuff to show you. Then the recording of the webinar will also be available on Facebook page. So if you want to share or revert back to any info, you're more than welcome to. Follow us on Facebook. If you haven't liked our page on Facebook, please do so, because we share a lot of information through our Facebook page. So I would like to thank Michael Farrow from STI for sponsoring the webinar this evening, and also just give you a little bit of feedback to who is STI. So STI was founded in 1972, and STI is fast becoming a world leader in specialized dental materials. And in 1955, STI was publicly listed on the Australian Stock Exchange. All of STI's products are manufactured in Australia, and all the products are sold through distributors and throughout the world in over 100 countries. The Riva Glass Ornament range, manufactured, very well known in South Africa and used by many of you already. So a very interesting fact is STI uses proprietary iron glass filler in their glass ornament range, developed by the glass technologist, which gives it the radiopaqueness, high iron releasing, and a bioactive glass. This is what leads to the high fluoride release in the Riva range. If I'm not mistaken, other manufacturers also purchase the iron glass from STI for their own glass ornament products. And this just shows you what a good product it is. So I'm very pleased to welcome Dr. Munther Sulieman on stage with me now to share his knowledge and experience with the South African audience. Tonight's lecture, I can see he's joining. Welcome, Dr. Sulieman.
Good evening. Thank you.
Welcome to the South African audience. I'm just going to share my screen to formally introduce Dr. Munther. Can you see my screen, Dr. Munther?
Yes, I can. You've got my beloved.
That's very nice photo of you. So, yes, Dr. Sulieman graduated at the University College Hospital and gained a Bachelor of Dentistry degrees with honours, and he completed his master degree from Bristol University in restorative dentistry in 2001. He is practicing dentist in London presently. With all that being said, he actually didn't want to be a dentist. He wanted to be a pilot. So hopefully someday you'll become a pilot. He is also a huge Liverpool fan and is very chuffed that they are the Premier League champions at the moment. The webinar tonight will be an overview of the use of bulk fill materials in dentistry as an alternative to conventional silver amalgam to reduce the environmental impact of mercury. All the available bulk fill materials ranging from various types of glass ornaments and composites will be discussed in terms of their properties and uses. Combination techniques will be covered, as well as the developing use of silver diamide fluoride in dentistry, and especially its use in the art technique. With that said, Doc, I'm going to hand back to you to entertain us. There we go.
With the Liverpool crest next to me than me doing anything, but I suppose we'll have to get started. Here we go. I'm going to start.
There we go. Perfect.
tell me if everything is okay before you go off stage.
100%.
Can you see my presentation?
Okay, perfect.
Okay, perfect. Well, welcome everybody in South Africa. I hope the weather there is better than the weather here, because I am sitting below a very large window and it looks as about it might collapse on me anytime because of the amount of rain we've got. But let's hope not. Okay, so tonight's lecture or webinar is termed to bulk fill or not to bulk fill. When are we going to be using bulk fills? Why are we using bulk fills? And what should we use for bulk fills? Are we going to use glass ionomers, composites, or shall we keep it smart and simple? Please keep that smart and simple in mind for later on. I'll explain why. So let's start. All this has started as a result of needing to find alternatives to amalgam as a result of the Minamata Treaty, where the use of amalgam has sort of been reduced due to environmental reasons. We're looking at different ways to replace amalgam, which has been a brilliant product for over 150 years, but time has moved on and we need to move on as well to reduce the impact environmentally. So when we have deciduous teeth, we are using things like glass ionomers, we're using resin modified glass ionomers, and we're using composites. For children under the age of 15, for their adult teeth and deciduous teeth, obviously, we're using the same sort of products. When we come to adults, we've got a few more alternatives here, whereby we've got inlays, we've got onlays, and crowns that we use. So there are a few alternatives there. Now, so what are the requirements when we look at bulk fills? We've got to look at it in terms of adaptation to the cavity. These are large cavities. The material has to adapt to all the nooks and crannies of the cavity. It needs to be able to actually, it needs to be cured to the full depth of the cavity. There needs to be low shrinkage, and at the same time, it needs to maintain mechanical properties in terms of being a high compressive strength and also display good wear resistance. So it's quite a tall order to look at when we're looking for bulk fill materials. When we compare glass ionomers to composites, and in terms of bulk fills, there's a number of different things we need to consider in terms of things like micro leakage, the technique we use for composites. What's the substrate like? What's the material that we're bonding to? Is it enamel? Is it dentine? What type of dentine? Is it sclerotic dentine? Is it a slightly demineralized dentine? All these variables come into play when we're considering composites. The depth of cure is very, very important. Obviously, mechanical properties is important for either composites or glass ionomers. Then the marginal seal. What type of seal is it? What type of bond is it? Is it chemical? Is it macromechanical? Does water affect it? Water with composites is a bad idea, but water with glass ionomers is not such a bad idea because it's involved in the actual reaction. And what is there in terms of ion exchange, fluoride release, and that sort of marginal integrity with the fluoride release? Is there an ion release between the filling material and the tooth structure? So there's a number of things that we consider when we're looking at glass ionomers and composites. Now, we talked a little bit about the adhesion. Dental adhesion is really important because it's actually it actually makes or breaks the filling, so to speak. Because if the bond gives, then it doesn't matter how strong the restorative material is or how well it's adapted to the whole thing will collapse because it's given way. So ideally, it should be a chemical bond. But in most of the times when we're talking about composites, we're looking at macromechanical bonds by the formation of a resin hybrid layer with interaction with the tooth. That is also a problem because it's prone to micro leakage. That hybrid layer is basically a mix of the adhesive material with the tooth tissue itself. And it's created by the diffusion of the adhesive monomers into the acid etched tooth surface. And so it produces a hybrid layer that is important in terms of the bond. It should be uniform. It should have no voids. So all these things come into play when we're looking at these materials in terms of composites. when we look at the glass ionomer bonding structure, well, that's much easier, much better. It's basically a polyacid, polyalkylic acid, that attacks the dentine and the enamel, displaces the calcium and phosphate ions, and there's also migration of ions the other way in terms from the glass, things like strontium and fluoride ions, the other way into the tooth substance, and it produces a chemical bond, which is a very, very strong bond. Obviously, stronger to enamel than dentine, but nevertheless, it is a very, very strong bond. So that's a true chemical bond. So when we're looking at glass ionomers, why are they so good? Basically, why are they important? They have a very good therapeutic property. They are really true bolt fills. You just inject the stuff in and the whole thing will set beautifully. They have no monomers, no free monomers. They don't have any BPA or HEMA available. There's a slow release of fluoride. Now that slow release of fluoride in terms gives you a better marginal seal, gives you caries prevention, and that fluoride is actually rechargeable, and we'll talk about that later. I've already mentioned to you that there is an ion exchange with the tooth. The calcium and phosphate ions go one way, the strontium from the glass and the fluoride go the other way, enhancing the tooth structure. And obviously it's a biocompatible material. So it's got a number of very important things to look at. When we look at the benefits of glass ionomers, they're relatively insensitive to moisture. We're not talking about you should have saliva all over the place, but you can quite easily isolate and put glass ionomer down, and you will still get a good chemical bond, as water is involved in the reaction anyway. So then you get a good chemical bond. It has long-lasting marginal integrity, as we said, because of the fluoride release. It has another important property. It has a low modulus of elasticity, so there's very low shrinkage. And that modulus of elasticity is very, very similar to a tooth substance. So that when that tooth flexes, that glass ionomer filling flexes with it. That's a very important property when you're looking at things like abfraction lesions, where we will mention later on. So this caries prevention with high potential for remineralization means that we can have a much more conservative procedure. It's usually a very quick procedure. And also, because it has a very low coefficient of thermal expansion, it's actually very favorable to the pulp, and you usually have very little sensitivity with this product. Now, I've made it sound like it was a wonderful, wonderful thing. It is for the most, but it has problems like any other product. Nothing is as good as tooth substance that God gave you. So glass ionomer still has sticky handling to worry about. It's still a little bit brittle. It's weaker than composites. It's relatively hard to finish and polish it. It has lower stability against erosion and abrasion, and lower sort of pore acid abrasion resistance as well. So it's not a perfect product. Now, if you remember, I said to you about ion exchange one way and the other. The ability of strontium and fluoride to diffuse into the enamel and dentine actually gives you a very good marginal seal and gives you a very good acid-resistant chemical fusion zone one way, and then the other way, as I said, from the tooth, the calcium and phosphate ions incorporate into the cement. So it gives you a very, very good bond. So where are we going to use these glass ionomers? Well, all primary dentitions, class 1, class 2s, class 3s, class 5s. You can use it as a base, a liner. You can use it as a core build-up material, temporary filling material. Anybody that has any allergies to resins. We'll talk a little bit about sandwich techniques later. In relatively moist environments, there is really no need for mechanical retention, and you can actually use it to control caries in moderate to high risk patients. So I get a patient in that has multiple cavities, left, right, and center. The first thing I do is I get glass ionomer out and I seal all of those cavities straight away, and just buy myself some time to actually go through and restore the rest of the dentition slowly as we go along. So it's a very, very good caries control restorative material. The atraumatic restorative technique and minimal invasive dentistry is a technique that's been around for ages, but now in the times of COVID, it has become a very important technique, especially when we're trying to reduce aerosol procedures, especially in Britain. I don't know what it's like for you in South Africa, but at the moment, when I'm practicing dentistry, I'm looking a little bit like Darth Vader with all the respirator masks and all the gowns that I'm wearing and God knows what else. and the visors and everything. And at the same time, I am supposed to be reducing aerosol procedures, because every time I pick up a drill or any high-speed drill or an ultrasonic or something, we have to shut down the surgery for an hour afterwards for fallow time before we can actually re-enter it and clean before we go on to the next patient. So it's not really very viable to keep doing this unless you have multiple rooms to hand. So these sort of techniques are invaluable at the moment, and especially combined with something that I'll discuss later, which is Riva Star, that I'm using these techniques more and more during these times. Okay, so we've already really mentioned intermediate and interim sort of therapeutic restorations, especially in old people as well, where I tend to use these sort of techniques to just basically calm the situation down and give the patient something to go away with without needing to work very quickly and sort of do everything at once. So the limitations of glass ionomers, I'm not going to be using it in extended cavities or where I have a high load, sort of dysfunctional high load situation whereby there's cost replacements or there's really big stress-bearing restorations. I'm also not going to be using it when I've got very wide proximal areas or in cases where I've got a very high aesthetics case at the front of the mouth. So it has got limitations. I'll just start by saying to you, whenever you use a product from SDI, usually you have more than one alternative. Just to keep it simple, a glass ionomer, which is Riva, this is a conventional glass ionomer that's self-cured, and the one on the right is basically wherever you see HV, it means it's high viscosity, and it's easier to handle because of the filler technology that I'll talk about in a minute. But usually, on average, most of the time, I will be using Riva HV for most situations, unless I'm using sandwich techniques, and I'll describe to you those later on. But usually, this is the thing that I think is more close to your heart in terms of actually use for actually using it as a filling material. If you're using it to line or situations where you want a good, very, very good seal straight over, then self-cure, normal self-cure comes into play. But we will talk a little bit about things now. So the high viscosity product, why is it different? As Tanya already mentioned, SDI are very, very good at their glass filler technology, and they're using the same sort of technology that they use for their composite with the use of hybrid glass ionomers. The glass filler content is hybrid, meaning that different sized glass particles that pack in and give you a very high filler load. That gives it very great, a lot of load strength because it's got a much higher load. It gives you very good durability. It gives you a better surface quality. The wear resistance is better. The bond strength is good. The compressive and fracture toughness is even better. And at the same time, it gives you a very good flexural strength with high acid resistance because you don't have a lot of that sort of the matrix around in between. It's mostly filler content. The reason it gives good surface quality, when you have glass technology, the fillers are different sizes because they're small fillers. Small fillers, when they come off a surface of a restoration, they don't really leave big holes. Whereas if they're highly filled and they've got big fillers, big sort of glass sizes, when the filler comes, the glass bead comes away, it leaves a bigger gap, and then you have less than ideal surface structure. So that's an important property. Because of all this technology that's gone into it, it makes it non-sticky and it's very good to handle and very, very close to, not quite as a composite, but very close. I do apologize if you can hear the rain in the background. I'm having to shout because it's getting heavier and heavier. And let's hope this window holds out. Okay, so let's move on. Where am I going to be using this materials? Well, as I said to you, class 1, class 2 cavities for adults, even as long as they're non-stress bearing, deciduous restorations, geriatric restorations, anything where I need to replace dentin, a high bulk of dentin to replace, I will use these materials. Class 5 cavities up to and close to the aesthetic zone, and in a lot of cases, I will actually use it in aesthetic zone as well because these products, the aesthetics of this product is not bad at all. We'll talk a little bit about the ART technique and the invasive dentistry later, as well as smart restorations, where I'll talk to you about those later. So, in addition to the normal conventional glass ionomer that we have, we also have a light cured version. So again, you have a light cured version and a light cured heavy body or heavy viscosity version. The good thing about these is their handling properties. The other thing that's very good about this product is it's made in a capsule that actually has a tip that is protected from the light. So it's almost like holding an orange barrier against the light. So I'm able to use this capsule all over the place in the mouth without needing to get another capsule because it stays not being activated. So it's a very useful property to have. You can actually use it very, very quickly. You can manipulate it after mixing straight away. You can sculpt it. It doesn't stick to instruments. Now, let me just give you a little bit of advice in terms of I use composite instruments to use with this product. I have a nurse at hand that has a tissue in her hand. Every time I handle, whether it's glass ionomer or composite, as soon as I move away from the patient, she wipes it dry, then I go again. That way I find there is no need to use things like wetting agents and bond and things like that. That is not something that I use. You don't need to use that if you use that technique. The product stays where you inject it. It resists that initial flow. It has a very high flexural strength and wear resistance. Doesn't really lift when you place it, so it's very, very good. It also has the advantage of it doesn't have BPA. You can polish it very well. It's acid resistant. It's also a chemical bond, which makes it a very, very good product to actually use on patients. So where do we use it? Exactly the same situations, but I tend to use it in more aesthetic zone because I want to be able to take my time and not worry about setting. And I can really take my time doing this. I do have a light on my chair that has a composite mode, so I've got plenty of time to actually sculpt this and build it up without having too many issues. Okay, let's move on and just say a little bit about glass ionomers and resin modified glass ionomers. The difference between them, you might say, well, what's the advantage of one or the other? Glass ionomers by themselves, the conventional glass ionomers, as good as they are, they release more fluoride. They have a greater wear though, so they wear much more, and they're not as easy to handle. Even though they're not bad to handle, they're not as easy to handle. When you go to the resin modified glass ionomers, you have less fluoride release, but you have much better aesthetics, you have better wear resistance, and much easier handling. So there's a trade-off here. But in most of the time, I will always use resin modified glass ionomers if I can help it towards the front of the mouth, the back of the mouth. I would more likely use glass ionomers, especially where I'm using them in sandwich techniques and so forth. And we'll talk a little bit more about that later on. Now, to add to this mix, there's also another very good product called Riva Silver. Now, Riva Silver is basically a conventional silver alloy reinforced glass ionomer cement, and it is mixed in a normal amalgamator. It's a liquid and powder mix, and it produces a very, very high radio opaque ion releasing product. The reason for this is because the fluoride is actually within the glass matrix itself without being bound by the whole structure. So the fluoride is released to the environment. Whenever there's lower concentration in the cement itself, it picks up the fluoride from the oral environment. So you can recharge this product. Any patient that has got a high caries risk, the back of the mouth where the silver doesn't show, it's not really, it's actually sort of a light grey material. It's not that obvious, but especially towards the back of the mouth, if you've got situations whereby moisture control is problematic in terms of subgingival areas for older patients, that the alternative is you've got subgingival decay, they're an old patient. What do I do here? Do I do a conventional crown lengthening surgery, wait 6 weeks and then do the restoration? Or do I think, nah, this is not going to happen? I pack in a little bit of retraction cord and clean out the cavity, and I'll use Riva Silver. And even with that sort of little bit of oozing from underneath the gum, it still bonds really, really well. And you get the added advantage of then putting that patient on a high fluoride toothpaste, then that will recharge the area. And I get them in the habit of saying, look, this is going to work depending on you. I need you to be doing this. And what they actually do is then they apply continuous source of fluoride to the area, and it continuously recharges. So when I say it continuously recharges, I mean, if you look at this diagram here, that's the fluoride within the glass ionomer. When the fluoride concentration is low inside the actual cement itself, it then takes in the fluoride from the environment, and then it passes it out to the tooth. So when you have a high concentration of fluoride within the tooth, or within the cement, it then passes it out to the surrounding structure of the tooth. So it continuously recharges, and it's a great, great product to use, especially on old people, especially in the back of the mouth where you've got these situations, root caries and stuff, and it works a wonder because those patients otherwise will lose a tooth. It's very difficult to restore these teeth sometimes, but with this product, it's really simple to use it. Okay, so you can use it again in a number of different ways, areas. I also quite like to use it in core build-ups, whereby you've taken off a crown, half the core is gone. You want a quick fix. Riva Silver is very, very good, but please remember when you are using glass ionomers generally with core materials, you need at least half of the sort of core to be tooth substance in there before you use the glass ionomer. You don't really want to just go flat and then just put glass ionomer on there. It's not really advisable. Okay, so you use that as a core build-up material. Right, I'm sorry, I keep looking up because I've got a lot of rain here. Okay, so let's move on. When and why do we use composites? As generally, they're a very, very good product. They're biocompatible. There is very good adhesion now to enamel and dentin. It's not a chemical bond. We know it's a macromechanical bond, but yet it's still a very, very good bond now. We have a number of different bonding systems that are available, and you produce really, really good substantial bonds now. And so that's a good thing with composites. The color, the use of the colors within the composites, the perception, the optical effects that we can produce now are amazing. You get very good harmonious blending to the tooth structure, and you can use it for a number of different things. So when we're looking in terms of treatment needs, we can use it obviously for caries, we can use it for aesthetic situations, for fractures, for malformed teeth, dysplastic teeth, discolored teeth, for erosive lesions, and also for abfraction. Now, abfraction, remember I said to you, glass ionomer is very, very good for abfraction. I would still like to favor glass ionomer for abfraction lesions because of the flexing of the tooth. The whole nature of abfraction is flexing of the neck of the tooth with people grinding or clenching their teeth. It does work very, very well, even with composites, but it tends to pop out whole. Whereas with glass ionomer, it tends to flex with it and last longer. So I tend to use resin-modified glass ionomers in aesthetic situations for abfraction lesions. But for patients that are aesthetically very demanding, I would still use composite, and it still will give you years worth of service. So it's still a very, very good product to use. Okay, little reminder of what composites are. Basically, we have an organic matrix, resin matrix, which is a fluid made up of a number of different monomers, and we'll talk a little bit about that in a minute. And with an inorganic matrix, solid component made up of glass and silica, which is very, very important. Then within that mix, there are coupling agents that ensure that the fillers bind to the resin itself, and also initiators and accelerators to activate the product, whether to cure it by blue light or chemically or something like that. So that is the reason why, that is the way the composition of composites are. Now, when we have resins and fillers, the resins are important because you have a number of different types of resins. I'm not a resin specialist or a filler specialist, but I do know that they can use a variety of different resins to produce that great combination of high filler content, as well as having that flexibility, that non-stickability, and all sorts of different things that you can do, and in terms of how you handle, how it handles, and so forth, and in terms of setting, and in terms of how little there is in terms of shrinkage and stuff. That is all set by the combination of the filler and the resins. So the fillers themselves, they can be classified by the particle size itself, the shape, and basically the load. So flowable composites tend to have a very low filler content, whereas conventional composites, they have a much higher filler load. Now, they classify generally composites in terms of the type of filler that they use, the size, in terms of whether they are macrofilled, microfilled, nanofilled, and so forth, and hybrids and nanohybrids as they are. The latest technology are the nanohybrid fillers, which basically means that you have different sizes of fillers. Now, I don't know if you're like me and you've ever wondered what really, how small these things are. I remember going into a factory in Germany to have a look at these things, and they basically produce these by sort of having glass balls being thrown at each other within this glass, and basically then sieving the whole thing down with these microfine sieves to produce the correct content of fillers. So just to give you an idea of what we're looking at in terms of how big things are. So when we're talking about microfilled composites, we're talking about a human hair basically has about 100 microns across, or a blood cell is about 8 microns in diameter. And now if you can think of nanometers, or even 1,000th of that, you'll understand how tiny these little things are. So when you mix these different sizes, you can pack in a lot more filler load into the composite and produce a much better composite product than before. And by having these different size filler content, you also produce much better resistance to a number of different things, including the ability to keep smooth over time. Because if bits come away from there, these are tiny little bits and they don't show up. Whereas before, when you had the macro filled composites, big bits came away. You had huge chunks come away from the tooth, from the composite, and you'll see big gouged out areas, and you see it, and that you see it very quickly because it attracts stains straight away. So these don't stain as much because of all this that's gone into them. So when we talk about Aura Dentine shades and Aura Easy, Luna, and Aura Bulk Fill, these are all SDI products that are based on nanohybrid technology. So these achieve these advantages in terms of this is the latest generation of composites. They have a very high strength. They have great aesthetics. They're really ideal. And I use them for at the front of the mouth and at the back of the mouth, which is great because quite often, years ago, you used to sit there and think, where shall I use here? Shall I use that for this? Where do I sort of draw the line between front, well, it's going to be aesthetic or not? With this, I don't need to. The high translucency, the high strength, the ideal aesthetics, I don't need to worry. I will just routinely use these products at the front and the back of the mouth. There are limitations in terms of the different products that they have, but you can use them. But today's webinar is too short to go into those limitations. Okay, so let's move forward. Let's look generally about composites and why they fail. Well, most of the time they fail because of recurrent decay. And the most common problem is actually at the gingival margin. There's gap formation at the base of, say, a class 2 cavity, and any size of gap will cause recurrent decay. So you can get this gap as a result of polymerization shrinkage. You can get poor open contacts, and it can also lead to postoperative sensitivity. So all these things cause these composites to fail. When we're looking at polymerization shrinkage, as I said, failure is always at the weakest link, which is the bond. So when you get that, you'll get secondary caries. You will then get marginal staining. You can possibly get tooth fractures, and because of this gap, you can quite often get tooth sensitivity. So your patient will have a filling and they're biting down, and you're checking and think, well, the bite is correct, but they're still having sensitivity. You can bet then you've got some sort of leakage going on here. Quite often, I mean, very rarely, you can actually abuse the bonding technique and cause sensitivity that way, but most often it's due to gaps that appear. When we look at polymerization shrinkage, the things to look out for, obviously you can see marginal leakage quite easily. White lines are a giveaway. You can get restorations, fracturing straight away, and cusp fractures occur quite often as a result of the shrinkage. Having said all that, the amount of shrinkage in most composites available nowadays is very, very low to 30 years ago when I started on this course of being a dentist. So it is much, much better. And what you need to remember also, you need to look at your box, especially in class 2 cavities. If you've got a lack of enamel at the gingival floor, really you need to think of something else. Composites will not work. So you need to think of glass ionomers or resin modified glass ionomers to actually fill that gap. Once you fill that gap, and sometimes it can be subgingival, once you fill that gap, then you can bond on with a composite on top. That will help reduce the gap formation. When you don't adapt the gingival margin very well, you can cause gap formation. So consider always using as your first layer a flowable of some kind. There is a product called Aura Easy Flowable, or Easy Flow it's called, I think now. It's a very, very good product. It's not that flowable actually. It's a good consistency where you just place it where you want and it doesn't flow all over the place, but it's still classified as a flowable because it actually wets the area quite nicely and adapts to the area, to the gingival floor very, very well. If you have poor isolation or you undercure your composite, you will also get gap formation. So these are the things that you need to watch out for. When we look at bulk fill composites, so why are we using bulk fill composites? Well, we are using them to reduce the time it takes to do a restoration. And actually, this may in turn reduce the sensitivity in terms of the technique. I'm not talking about sensitivity of the tooth. I'm talking about the sensitivity in terms of who the operator is and what they're doing. This reduces that because you've got less increments to work with. Generally, you're working with 3mm plus increments compared to the conventional maximum of 2mm. When I say 3mm plus, we're talking things like Aura bulk fill. You can actually quite confidently cure 5mm because the product actually, when they test it, cures up to 10mm. And there is a reason for that, and I'll talk about that later. But you can quite honestly cure up to 5mm as well. That doesn't mean to say that in every situation you should be curing 5mm, and I'll explain why. Well, in fact, it was in the previous slide where we talked about the C factor. You need to still reduce the risk of polymerization shrinkage by, especially in class 1 cavities, perhaps do it in 2 increments rather than 1 increment, less than 5mm, to reduce that polymerization shrinkage. It is still very, very low, but I would still do it in 2 increments because I reduce the risk of polymerization shrinkage. Okay, so bulk fill composites, they're available in what's called the high and low viscosity. There's also light cured, dual cured types, and added to this mix, there is a sonic activated bulk fill composite, which I'll talk about briefly as well. So the types of bulk fill composites you have the original, the SDR product, which is the low viscosity flowable, basically flowable material. Very, very good product to use. The only problem with it is it looks awful and you have to cover it with something. It's not nice. There are other alternatives, but they all share the same thing. They're very, very good products to use, but conventionally you need to cover them with something. So if you need a capping layer on them, I tend to sort of stay away from these composites. Whereas the high viscosity composites, such as Aura bulk fill, they are very, very good products. I will always though, regardless of anything I do, when it's a class 2 or a class 1 cavity, I will always try to wet the floor. I don't mean wet the floor, but use a flowable composite to start with as the base layer and then move on from there. I just find that a much better idea, and I'll explain why in a minute. Then added to this mix, there is a sonic activated composite, which is made by Kerr. It's sonic fill. That has a different property. It's basically injected into cavity using sonic technology, and then as you take away the sonic technology, it starts to harden up and become a different consistency. And by the time you've activated with a light, it's fully cured. So that's a different product. Okay, so when we look at traditional versus bulk fill products, traditional composites versus bulk fill. So with traditionals, you can use up to 2 millimeter increments. With bulk fills, you can use up to 5 millimeter increments. You are doing this to ensure the depth of cure and also reduce polymerization shrinkage. I would actually say to you, regardless of what you're using, try not to do it all in one go. Even though you can, I just like to go in with a sort of belts and braces approach to reduce my risks for the patient, and I'll always do it that way. Having said all that, you know, my MSc, I did a 3-year study on composites, and we used to have to do lateral curing techniques. We put less than 2 millimeter increments, base layer, then lateral layer where you cure this way, you cure that way. It used to take forever. Now, even conventional composites don't take forever, but with the bulk fill materials, they really do simplify things. And especially for somebody who is not that great with composites, it makes it really, really easy for them. A couple of increments and you're done. It buys time, it buys you time, and it makes life so much simpler for your patients as well, that are sitting there with their mouths open. Okay, so let's look at low viscosity bulk fills first. Why are they good? Well, they're very good depth of cure because they've got no fillers inside them. If there are no fillers inside them, when you shine the light on there, it goes all the way down and you actually activate it very, very well. So there's very little shrinkage. There's no disruption of bond because the material's elasticity is very, very similar to the you know, it's mitigated by the polymerization shrinkage. Is very, very similar. It lacks the appearance. It lacks the strength. It's not that strong because it's not filled. So you need something on top. And the wear resistance is pretty awful as well. So generally, I don't like to use these for that reason. However, when you're looking at the high viscosity bulk fills, they have great strength and they have great wear resistance. The adaptation to the cavity of the wall is not as good as the low viscosity, obviously. However, as I said to you, I'll always use a low viscosity sort of flowable composite below that, or a resin modified glass ionomer if need be in those situations where the gingival floor is subgingival, or I'm not happy about the isolation there. I would use that sort of material. But generally, you know, it's a trade-off, but that trade-off actually works very, very well. So when should we be using bulk fills? I think you need to still remember that your principles for the C factor still apply, and then use them that way. Consider using them even in class 1 situations, but not necessarily in one increment. Do a couple of increments. That will reduce your risk, and also by using a flowable composite underneath there, that will reduce your risk and make sure you've got nice adaptation of the cavity. Generally, this is not a bulk fill, but generally the bulk fill materials tend to be less, they're more translucent than usual, but actually the oral bulk fill is actually got a very, very good, aesthetically, it's very, very good. So the other materials, if you've got a discolored pulpal floor from previous amalgams and stuff, if you use some sort of opaque flowable composite on there, that would be a good idea. But again, generally with some of the cases that I'll show you, you'll see it's not been a problem with the oral bulk fill that I've used. So you need to be a bit careful with what material you're using, but by all means, try a few of them out and see for yourself, even if you're not confident using them on people's teeth, you know, on patients, get an extractor tooth and have a look, take out a cavity and just put some of this stuff in and see aesthetically what your sort of results you're going to get. I don't think you'll be disappointed. So this depth of cure business is very, very important. And so the problem for bulk fills is they want to really reduce, they want to make sure that the whole cavity is cured. So there's a trade-off. They either sort of they either reduce the filler content, making it weaker, or they sort of increase the filler size, or they add, some companies add different photo initiators to their product. So there's a number of different things. So, and remember also there's a drop in the light intensity with distance from the light tip to the bottom. So there's a number of different issues in terms of the depth of cure. When we go for, we'll talk a little bit about aura bulk fill in a minute in terms of how they get past that problem. So marginal adaptation, we said, you know, is there a problem here with adapting these materials? Well, the studies that have been done, they've not really been very conclusive in terms of whether marginally, you know, the adaptation with conventional composites is any better than bulk fills. I think the important point here is got to be the depth of the cavity. The deeper the cavity, whether it's conventional or bulk fill, it is more difficult to actually get good adaptation. So some people have used, as said, sonic activation. Some people actually heat up their composites. Quite often, you know, some people do that. They think it works best, and some people I know have very great results with it. I have to say, for me, I'll always use flowable composites to sort of seal the base of the cavity, and then I will use my bulk fill materials. And looking back over a number of X-rays that I've taken afterwards, the actual adaptation looks very, very good. So I've never had any problems. And obviously, you can use a dual cure material as well. That's a little bit more flowable to start with, and then it sets with time. And you just seal the top of the product in terms of with an activation for the top, and then you rely on chemical activation to do the rest. There are a number of different products out there. Okay, so just to talk a little bit about aura bulk fill, because this is the product that I like to use. It's based on barium glass fillers, as we said. They're pre-polymerized, so they actually produce this product and then they go back in, break it down again, and produce set material within the unset matrix that you've got, so that way they reduce the polymerization shrinkage, and then that way they can have a number of different filler sizes to produce a very, very good product. And as I said to you before, manufacturers tend to use different resins to produce different effects, and they produce that to give you good handling properties, but also the other reason they use these materials, the different monomers, is to actually produce, to play about with the refractive index of this product. If you recall a few slides before, I said to you, different manufacturers use different methods to actually ensure a depth of cure. So what they do, SDI here, is they use different resins, and what happens is when you have uncured resin, the refractive index of these resins, they are actually matching the refractive index of the filler content to start with, and as they cure this product, the refractive index changes. Don't ask me how it changes, but they assure me that it changes, and then by the end it doesn't match anymore, hence you get the aesthetics back, but by that time you've cured all the product all the way down to the end. Initially I was a bit skeptical with all this, but they've got a very, very good little plastic thing, a ring, whereby you have a number of sort of millimeters, you put the composite down and you cure it, and then you can split this ring and have a look, and lo and behold, it does cure, and it cures very well. And that plastic ring cures to about 10 millimeters. So, but I think under the guidelines from I don't know what is it, the testing authorities, the standards authorities, is it ISO or somebody, they can only declare up to half the amount that it says it does. So 5 millimeters, it definitely does. And I will say that if you do get a chance, try it for yourself. Those little rings work very well, and you can prove to yourself that it does actually cure to that depth of cure. Okay, so I think I've mentioned this already. It produces, and you get a very, very good finish. Now, there is only one universal shade, but fortunately for you and I, that universal shade that they've actually got is actually quite good, because it's almost like it has a chameleon effect. It's almost like A3, A3.5, that sort of Vita shade guide effect. And for most of my patients, it seems to blend in very, very well at the back of the mouth. And I'll show you a few cases, and then you can see for yourself. So where am I using it? I'm using it for posterior restorations. I'm using it obviously as an amalgam alternative, as a core build-up material. And generally, if I want to quickly splint some teeth, I will also use it. It's a very, very good product to use. Don't take my words for it only. I don't know if you guys look at Dental Advisor, but Dental Advisor seem to agree with me. It is a very, very good product with, excellent features, really. And a lot of their test advisors have recommended this product. So I'm going to quickly show you a few cases. So I said to you, class 1 cavities are a bit of a problem. This is quite a deep cavity. So I will always do this in terms of a flowable composite first, right at the base, and then I'll do it in 2 increments. And you get a reasonably good aesthetic result, I think you'll agree. It's not too bad, and it blends in very, very nicely with that. The next tooth here, you've got a couple of teeth here. The cusp went, and the whole product was replaced. The whole filling was replaced here, and at the same time, this very large, deep cavity here again was also replaced at the same time. And I think you'll agree it doesn't look too bad, and that's immediately afterwards. And you'll tend to find that with time, it seems to sort of blend in a little bit better because, let's be honest, teeth are slightly dehydrated to start with, and things change with time. Now, this gentleman came in, he needs a lot of treatment, and to stabilize his mouth, we wanted to do something very quickly. And what I did here is I used Aura Bulk Fill very, very quickly. And then later on, I went on to use the Aura Bulk Fill to also build up a core for a tooth that I will definitely be crowning. Okay, so this is the same product. You'll see it looks a bit light at the moment, but with time, it actually blends in. The problem with something like this is patients actually quite like these, and then they don't come back and have crowns done, which is not a good idea because they need them. The same patient, no, this is a different patient. Again, very large amalgam filling, and again with a cusp replacement as an immediate replacement sort of filling. This is something that we did using bulk fill. Now, this gentleman here also had a lot of problems. He has implant crowns and a broken down filling here. It might look like an ordinary filling to you, but believe me, it was a very, very deep filling. And again, this is slightly dry, and this is, once it's been polished, it produces a reasonably good aesthetic result for most of my patients. They're not going to complain too much. Then you've got big, big, big fillings like this, whereby you've taken out a very deep amalgam, and you get a very, very good aesthetic results using bulk fill. Please remember that these are not necessarily 1 increment jobs, although some of them can be. A lot of them are just 2 increments, just to be on the safe side. This is a cusp replacement. The filling quite stained, cusp replacement, and then we decided to do the other filling as well, and we did that both straight away with this product. I am moving on. I'm not really sure how we're doing for time, but I'm moving on to the sort of final slides. Right, let me talk a little bit about infected and affected dentine and ART techniques. So when you have a cavity like this, the inner, so we've got the outer infected dentine is useless, we remove it, but the inner affected dentine has a little bit of bacteria in it. It can be remineralizable. It is still vital. It is still sensitive. What you do is you remove the surface stuff, clean up the edges, and then you leave the rest behind, and then you seal it with glass enema. That's the whole idea of the ART technique. And it's especially useful in the field in terms of if you have to go out into, I don't know if you guys go out to townships and places like that where there's a lot of work that needs to be done. All you need really is an excavator and glass enema, and you can use this. it's a very easy product to use, a very easy technique. Very underused, but as I said to you now, with COVID times, we are using these techniques a lot more than we used to. Now, if you remember my slide, my lecture started with saying to bulk fill or not to bulk fill, or shall I keep it smart and simple? Well, smart is a technique whereby we're adding silver modified, so silver diamine treatment to the ART technique to produce a filling that is bactericidal. And what do I mean? Basically, you can leave the caries in situ. You're not going to be removing all these caries. You are going to be treating this caries instead of just the normal ART technique. You're not going to be just removing the odd bits of caries. You're just going to remove as little as possible from the edges, from the EDJ. The rest of it can stay, and just any loose bits can be removed away. And then you're going to be applying silver diamine fluoride into this protocol to then kill off the bacteria and kill off and form a seal, a bacterial seal below your filling. So this product is called Rivastar, and Rivastar actually has the silver fluoride and ammonia inside it in one capsule, and then you immediately apply the potassium iodide in the other capsule. Why do you do that? Well, you do that because it scavenges the free silver and it reduces the staining. So how does this work? We have a mechanism of action whereby the silver diamine fluoride, the silver is antimicrobial, the ammonia is merely a solvent, and then the fluoride is for the remineralization of the product. So the mode of action is you have a very high pH of the silver diamine fluoride. It's bactericidal. It encourages the precipitation of the minerals within the caries to increase the radioopacity of the cavity with time. So you know how this product is working, and it's actually taking effect. Over the years, you will see, over weeks and months, you will see, if you take an X-ray, you will see further and further deposition of sort of more radiopaque stuff between where the decay was and the nerve. So you will see it for yourself that this is happening. When you apply the silver diamine fluoride, you then apply immediately afterwards the potassium iodide. That drops the pH, but it forms a stable subsurface bactericidal seal underneath there. The silver complexes that are bound to carious dentine will stay there and form a seal, whereas the fluoride will then penetrate through, and actually it penetrates through to sort of 10,000 parts per million sort of concentration, which is more than twice what we have in things like Durafat, and it's ongoing action. This whole thing continues to work, and it encourages the remineralization of the decay. So it's a very, very good product. So it denatures all the protein, the silver, it breaks the cell wall of these bacteria, it inhibits the DNA replication, and it basically produces a plug to the tubules to stop anything further going down towards the nerve of the tooth. Whereas the fluoride obviously promotes the remineralization. It also produces fluorohydroxyapatite. It inhibits the demineralization, and obviously at the same time is bactericidal in its own right as well. So it's a very, very good product. Now, silver diamine, the use of silver is not new. The problem was it used to stain cavities, but by the addition of potassium iodide, that scavenges the free silver ions. It produces a white precipitate, and then you basically continue to do this until you have a clear area where you see nothing there. You don't have any free silver around. That's when you know you've done the procedure. We don't have time for me to go through the whole procedure, but I need to just continue so that you can see what I'm talking about. We've mentioned this already. So what you're actually forming is a precipitate on the surface. It will decrease the permeability of the tooth because of the blocking effect. So technically nothing can get through, and you're producing the seal. So it forms either sclerotic or calcified dentine underneath the restoration. So Rivastar is, as I said, it's not new, but there are studies out there that actually prove that it is a very, very good product, and it works without causing staining like the previous products that were available. Now, when we, I'm just going to skip through because I think I'm running out of time for this presentation. You need to remember one thing. You cannot use this product on symptomatic caries patients. If they're symptomatic, no, you're going to have to go the conventional route and possibly do some sort of root treatment or something. But if they're not symptomatic, then actually the procedure, in fact, let me just explain to you what the procedure is. It's very, very simple. You're cleaning out at the edges of the cavity, then the mushy decay that you see, and it can be quite mushy decay, and you're using it in these sort of circumstances. You basically use a probe just to agitate it and just flick off any loose bits. Then you etch the whole cavity. When you etch with phosphoric acid, you etch it for 10-15 seconds, then you wash it all out, then you apply the silver on there, and then you immediately apply the potassium iodide on there, and then you wash the cavity, and then you will place your glass ionomer on top. Now, if it is a single restoration, you can actually just use, so this is something that's very kindly been presented from Jeff Knight. You'll see this is the sort of appearance that you will see after it's been treated. Okay, you've cleaned out the cavity. This is all mushy stuff that's been treated, and that can stay in there because that's what's going to produce the actual seal. You need all that bacteria, you need all that dentine there with the mushy dentine to actually produce, to precipitate the ions from there to actually produce the seal that you'll eventually get. I've already mentioned we etch. Why do we etch? It's to actually encourage the penetration of the silver iodide complexes within the deep within the collagen protein within the cavity to actually give you a good seal, bactericidal seal. Using polyacrylics or polyacids in terms of the conditions for glass ionomers don't really assist in that same fashion. They just don't have that same ability to do that. And incidentally, I actually tend to etch even for glass ionomers normally on the normal case, a very short etch rather than use conditioners. So when we're talking about smart restorative techniques, if it was a single surface cavity, I would use Riva Star and a conventional glass ionomer. As long as you haven't got a huge load-bearing area, I would use that. If you are using multiple surfaces, i.e. glass class 2 cavities and stuff, I will actually tend to use a sandwich technique. Now, this is a special sandwich technique in terms of it's a co-cured sandwich technique. The product itself uses glass ionomers just like the original sandwich technique, except in this case, what we're actually doing is we are using a chemical cured glass ionomer, so Riva self-cure or Riva self-cure heavy body, and after you've used the Riva Star on a class 2 cavity, you've used the Riva Star, you've washed everything out, I then tend to re-etch the enamel of the cavity, and then I've isolated. I then use glass ionomer such as Riva heavy body self-cure, and then immediately when I'm doing that, as soon as I've put it in, I will use a resin modified glass ionomer bond, something like Riva Bond LC. It then actually bonds between the glass ionomer and the composite itself, and you do that straight while that is actually setting. You can do it afterwards if you wanted to, but I usually set it, I actually use it straight away because it helps me then pack down the glass ionomer quite nicely and wipe across the whole, the dentine, the enamel, what's left over with the Riva LC bond, and then I tend to cure. Once I cured that with a light, then I will then use the composite on top. So that's why it's called a co-cured composite sandwich composite technique. It's a very, very good technique, and it tends to be work very, very well for large cavities at the back of the mouth, especially class 2 cavities. Okay, just the final few slides. Again, this shows you now Riva Star. If you just leave the cavity open, it will pick up sulfur from compounds from the oral environment, and also will stain. Just in the same way as arrested caries in the mouth will actually absorb the chromogens from the environment and stain, whereas with the use of potassium iodide and with the use of putting a glass ionomer filling on top, you will actually not get any staining. As you can see here, after 3 years, they've removed that and there's hardly any staining going on. Okay, just one final slide, just show you somehow why this technique can be useful. One of my patients who had a very old Maryland bridge, as you can see, it's very old because I used 2 wings, whereas now we'll only use 1 wing rather than 2 wings. But this is a long time ago. She developed decay here, as you can see underneath there. I couldn't see how close it is to the nerve, although the X-ray doesn't show here. As you can see, there's no apical area or anything like that. What I did is I used the tunnel preparation, and incidentally, those techniques that I talked to you about, we use in Rivastar and glass ionomers and into class 2 cavities, ideal for tunnel preparations. But I don't have enough time to talk about that today. But I just thought I'd show you this tunnel preparation. Then we used Rivastar on there, then glass ionomer, and then some composite on top. And so I was able to repair this without taking off anything, without doing anything. And I didn't have access to it from Buckley to do this. So it's a really nice technique to have to hand in our use for our everyday dentistry. I think that, oh, actually, no, I've got a few more slides. These are slides, again, from Jeff. Very substantial bits of decay here. Again, tunnel preparations, used the Rivastar, and he used glass ionomers. And then you can see post-placement, and then you can see 6 weeks after placement. That's the result. There is a fill-in of the minerals in that area. I think it shows a little bit better here. In this slide here, you can see substantial decay here, and you can see that there is going to be a filling of this material going, as you can see, closer and closer to the nerve. Okay, I think oh no, that's a better one here. It's 14 months here. As you can see, this is at placement. So this is the initial lesion. This is at placement. And now 14 months later, you can see there's almost like a bridge of calcified dentine there that is formed as a result of using the Rivastar and this technique. Right, I thank you very much. I'm now about to stop sharing the presentation, and I thank you all. And I'm going to hand back over to Tanya, who should be able to take over from now. Thank you very much. Thank you for listening. And hopefully there are still some people still out there. I see there's still 144, so that's not bad. I don't know how we got.
No, very good. They're sitting still. Thank you very much, Dr. Sulieman. That was an excellent lecture. We've got 2 questions here. When using a flowable and interproximal box or base of the restoration, should it be light cured first before you put the next layer of bulk fill, or can you do both together?
Always cure it first. You'll only need a 10-second cure for that. That's always first. No.
Okay. Then the second question is, I've never used Riva products. Do Riva glass ionomers require dentine conditioning?
Well, yeah. Well, yes, I did. Let me rephrase that. For years, I have used glass ionomers without conditioning. I've never had a problem. Okay, but if you really want that extra sort of assurance, you should condition a cavity. Quite often, I don't use the conditioners, the normal conditioners. I quite often use the etch. Whether it's right or wrong, I'm not 100% sure in terms of scientifically, but I know that macromechanically, I will get a very good effect. In terms of chemical bonding, I'm not sure. If the preconditioner may be better, I'm not sure. But macromechanically, I will use that. But having said all this, I actually use a fluid abrasion system. So every cavity that I prepare, I will actually go around with an alumina or silica powder cleaning around the edges. So I will use that. So I tend to do a number of steps anyway. So I've never had a problem, even if I didn't use a conditioner. I don't think I'll have a problem because I use the fluid abrasion. But there's no harm in it to use. It's recommended.
Okay, and perfect. Okay, I can't see any other questions. So I'm going to share my screen quickly with the promotions.
Not a very demanding audience. Thank you very much.
You did your job well.
Or I bored them stiff. They don't want to hear me anymore.
Okay, so Aura bulk fill. I know that in the South African market, this product's already very well known and very popular. I hear a few questions coming through, so we'll answer them at the end. Aura bulk fill syringes, 4 gram, 551, 53 cents, and then also the Aura bulk fill. I must say the bulk fill capsules sell better than the syringes. I think it's just comfort of use. And then the Riva powder liquid kits are all on promotion. And then this is the teddy bear that you get free with your powder and liquid kit if you buy. Well, it actually ends the 31st of August. So you've got tomorrow and Monday left for this promotion. And then very, 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 very nice bucket list thing. I don't know if all of you know about our Grand Prix trip. So how it works, if you buy between March and December of this year, COVID messed up a few months there, but 8 boxes, for every 8 boxes you buy, you get 1 ticket into the draw. And then our auditors will do a draw in January, and then a doctor and his partner or her partner will win a ticket, all expenses paid, to the Grand Prix in Melbourne. So the date for the Grand Prix was supposed to be in March, but I know that they are postponing it. But it doesn't mean that the incentive or the promotion is cancelled. As soon as a new date opens up, then that person that will win will go to the next event. Then also a very nice special tonight is fill a box. So 4 boxes of Riva, the capsules. You can choose any. So if you want 4 light gears or 4 self-cares, that's fine. Or if you want to mix it, light care, self-care, you can build your own box, which is it's a nice special altogether. And then on the Riva Star, not very well known or not widely used in South Africa. And I think this is a product that has a lot of feet, especially if you look at some of our rural area or outreach areas where this can be used quite nicely. Okay. Okay, can I see any? I'm just going to check for more questions. I hear, oh, it's just thank you, awesome presentation. They're just praising you, Doctor.
Thank you.
My pleasure today.
Next Monday I'll come over and see you guys in real life.
In real life. Dr. Sulieman is also a big expert on whitening, tooth whitening. So we'll look forward for that one or to that one. No problem. Thank you, Dr. Sulieman. Thank you for your time. Thank you for your sharing your expertise. I think then that's a good night.
Thank you very much.
Thank you everyone for joining us, and good night.
Night. Thank you.